Okay, well, thanks again for the organisers for this second opportunity to talk to you. So PopART was introduced. It's one of 3 trials that were funded by OGAC PEPFAR last year. This is one going through the NIH with extra funding from the NIH and a large amount of funding also from the Bill and Melinda Gates Foundation, who are partners of this trial. It's one of, as François Davy introduced on the first day, it's one of a number of forthcoming cluster-randomized trials. So PopART is also known as HPTN 071. It's an HPTN trial, and it stands for Population Effect of Universal Testing and Immediate ART to Reduce HIV Transmission. A large number of people involved, a rapidly growing list. The PI for the study is Richard Hayes at the London School. The co-PI is Sarah Fidler at Imperial College. I'm in charge of mathematical modeling at Imperial College and health economics with Peter Smith of the Business School. The site PIs in Zambart are Helen Ailes and Nolde Byers in the Desmond Tutu TB Center in Stellenbosch. Disclaimer, it's an important disclaimer. The protocol that I'll present to you is not finalized and is subject to making sure we get the best possible outcome while working within the budget. So it may be subject to substantial changes under ongoing revision. What is the PopART package which is being delivered? It's a combination prevention package, the key element of which is universal voluntary HIV testing delivered through a house-to-house campaign, male circumcision offered to men who test HIV negative, immediate ART offered to all who test HIV positive, counseling and condom provision, strengthening of PMTCT services, and syndromic STI treatment at clinic. The key delivery mechanism of PopART are the so-called CHIPS teams, that stands for Community HIV Providers, and they will deliver testing, counseling, linkage to care, and treatment support in a house-to-house manner in annual campaigns. So this is through the communities these workers turn around. We hypothesized additional benefits of the intervention at both the individual and public health level. As has been discussed, we hypothesized reduction in morbidity and mortality in those receiving ART earlier during the course of infection. We think this is a great simplification, and therefore in how ART is delivered, so not having to go through the CD4 count and just the immediate referral, and that can increase the overall proportion treated and suppressed by shortening the treatment cascade where people get lost, that there will be reduction in adverse events of treatment with earlier start of treatment, reduction of clinic burden of TB and other illnesses, potential elimination of mother-to-child HIV transmission, and that eventually such an intervention would be cost-saving. Importantly, the universal aspect of it, we hypothesize, would normalize HIV status and actually reduce HIV-related stigma. And it reduces through the universal delivery, reduces the need for specially targeted interventions. Given the discussion in this workshop and the subtitle of the workshop, I think it's important to ask why a trial is needed. It is needed because it's not known whether UTT intervention can be delivered with the high uptake and acceptability. There are many uncertainties in the model parameters telling us how this will reduce incidence. The population level impact of a feasible intervention package is not known. There are many potentially adverse effects, both at the individual level, like toxicity, drug resistance, and also sexual risk disinhibition, HIV-related stigma, overload of health services. And a rigorously designed trial can measure the cost of benefit of this strategy and provide reliable evidence on cost effectiveness for health policy makers. I would also refer you to the talk I gave yesterday on 7 reasons why, despite the success of HPTN 052, things could go wrong, and therefore we need a trial to test. It's a 3-arm trial with 24 clusters, of which 15 are in Zambia and 9 in South Africa. You'll notice the asterisk, which refers to the disclaimer at the start. A cluster is defined as the catchment area of a health center. There are 30 to 60,000 people in each cluster, of which about 50% are adults, maybe 60% in South Africa, 50% in Zambia. So this intervention, or this trial, will cover a population base of 1.2 million people. The clusters will be randomized to one of 3 arms. Arm A will be the full PopART intervention with the CHIPS teams, universal ART, male circumcision, and so on. Arm B will be identical to Arm A, except treatment will be initiated according to national guidelines, which are currently CD4 less than 350, and Arm C will be standard of care. The outcome will be measured in a population cohort to be recruited at the start of 2,500 adults in each of the 24 clusters, who will be followed to determine incidence after 1 and 2 years. The primary outcome is 2-year incidence in a population cohort. There are several selected secondary objectives, some of which will go ahead for sure, and some of which will be subject to the disclaimer at the start. Sexual risk behavior, which we hypothesize may increase or decrease, HIV-related stigma, community viral load, HIV-free survival of children born during the intervention period, provision of PMTCT, HIV disease progression and death, ART toxicity, ART drug resistance, prevalence and case notification rate of tuberculosis, clinic burden by reason for attendance. The plan is that the household mapping should start in the 4th quarter of this year, and that the intervention should start at the start of 2013 with the first round and recruitment of the population cohort, second round of intervention delivered in 2014, and the return visits to the households in 2015 and analysis through 2016. I'll speak now specifically about the mathematical modeling and its role in PopART. There will be 2 distinct parts of mathematical modeling, one which has already happened, which I'll describe the results of, and a post-trial. Very different models with very different aims. The aims of the pre-trial model was to develop the targets and try out concepts and to continue to refine their design. In the post-trial period, it's to aid interpretation and extrapolation of the results, so interpretation of a combination package, which is difficult, to try and understand differences in the different clusters, and to extrapolate this to national and international policy. The structure of the pre-trial model is simple and deterministic. The post-trial will be individual-based stochastic. The data in the pre-trial period matched to UNAIDS data and the pilot from Zambart, and then the post-trial data fitted to the trial data. And the initial model did not contain a health economics submodel, and the post-trial model will. HIV models, an overview. So I'm privileged enough to work across a range of infectious diseases. HIV models are, in a way, uniquely difficult because there are many things you need to know in order to make predictions, and you can't skimp on any of these. They all matter, as was discussed in the modeling session yesterday. You need to know about sexual mixing and heterogeneity in sexual behavior. You need to know about disease progression and how infectiousness changes with disease progression. You need to know the process of ART, the process of testing, of how treatment pans out, heterogeneity in treatment outcomes and failure rates. And you also need to know one bit which is often neglected in models. You need to know about the underlying demographics, age structure, growth, and population growth rates if you want to make predictions for the long term. So and now I'll describe the pre-PopART model. We used a conventional structure for risk groups and sexual mixing, where we divided the population into 3 types: high-risk individuals, medium-risk individuals, low-risk individuals. They could be female, male, or male circumcised or male uncircumcised. Medium and low-risk people tended to form partnerships. Low-risk people tended to form longer duration partnerships amongst themselves. It's about the split of the population was fitted to epidemic data, and that gave us approximately 20%, 20%, and 60%, and with higher rates of transmission and random mixing in the high-risk group. One of the major pieces of data which is incorporated in this model is a huge reanalysis of many disease progression cohorts from the Cascade data published last year, showing that our previous models of CD4 progression were not quite right. A lot of people, surprisingly, progress to very low CD4 counts very quickly after infection, and people with high CD4 counts progress to low CD4 counts more slowly. So when you translate this huge reanalysis of the Cascade data, with the caveat that it's predominantly subtype B infection, and that the investigators were not able to find consistent patterns for the other subtypes in African settings, so we generalized from the subtype B data, you get this model of disease progression, which is that from acute infection, which we measured at 2.9 months, people progress immediately after acute infections to one of the 4 CD4 categories, and you then get progression through the CD4 categories. This is important because it actually changes the impact of the arm B, of targeting CD4 less than 350s. The infectiousness was based on a reanalysis we published a few years back of the RACI data, which I alluded to yesterday. Acute infection, 26 times more infectious, and end-stage disease, 2.3 times more infectious. Treatment failures, because we were only interested in short-term predictions in this model, we used a very simple dichotomy that people were either treated or untreated and flowed back and forth, which is the structure that was used in the Greenwich-Style model. Obviously, we need a much more refined understanding of treatment failure rates, but there's plenty of data to do that in the detailed model at the end. The model was fit to national epidemics in Zambia and South Africa. In green, you can see the prevalence, and in red, the incidence. We factored in the local sites, the clusters, we factored in the impact of ART, existing ART use, which is where you can see an inflection point from about 2004 onwards. And the green dots you can see are the prevalence in all of the 24 clusters, which are the PopART clusters. So you can see prevalence ranging from below 10% with an average of about 15%, and a number of sites having 20 to 25% HIV prevalence. Based on the mathematical modeling and trying out lots of different scenarios, we settled on some targets. We actually have multiple sets of targets, but I thought I would show you our central target at this point. The annual coverage of the test and treat campaign, by which I mean the proportion of people who make it right through the cascade, so of HIV-positive individuals who initiate treatment and obtain viral suppression. Our target for that is 75% per year. For the failure and dropout rate, 10% per year. The effectiveness of blocking ART in blocking transmission, 95%. Take-up of male circumcision when offered, 50%. Contamination, that is a proportion of sex acts which are in between people in the community and out of the community, 5%, and behavioral change based on disappointing trials over the years, we assume no impact of 0%. The predicted impact of the intervention is shown here in Zambia and South Africa on incidence. The sawtooth pattern, which you might find a bit disconcerting, the incidence is coming down and then rising back up, is due to the fact that the intervention is targeted over 6 months, and we assume a dropout out of the intervention when the CHIPS teams stop their activity. In numbers, then the predicted reduction in yellow for arm B, and which is a restricted PopART package following national guidelines, and in red for arm A, which is a full PopART package, is 62% over the 2 years, and you can see a ratcheting from 53 to 72% in year 1 and year 2, and in South Africa similar numbers, and for arm B 27% reduction in incidence overall, with 23% and 33%. Just in terms of the model, our aim was to make this an uncontroversial model, and you can see that in the model comparison it's a yellow point highlighted as Fraser, and basically the model in terms of structure does not differ substantially from the other models being used in the literature. In a sensitivity analysis, you can see that with a lot of uncertainty about our various parameters, behavior change, dropout rate, and so on, that we varied over a range, that results in a lot of uncertainty in the predicted reduction incidence. So the trial will obviously be hugely informative in terms of where this actually falls. We also, from the sensitivity analysis, sort of rank, I showed this graph yesterday, rank the importance of the various outcomes in terms of their influence on the outcome. The influence on the outcome is a slope. So what this means is, for example, the first line, that the effectiveness of ART in blocking transmission, a 1% increase in effectiveness corresponds to a 0.93% increase in the overall reduction in incidence. So in conclusion, PopART is well powered to test universal treatment as prevention as part of a prevention package. The chips, we think, are the key ingredient, will promote universality and will need to promote high coverage and adherence, but we think this is the right model for this setting, and the trial will tell us whether we're correct. And specifically, mathematical models will help interpretation and extrapolation. Thank you.